Community health workers are the largest primary health network on earth. I think if we get AI right, it can be a genuine co-pilot for that workforce. But if we get it wrong and we deploy it without the people, the training, the professional foundation underneath, we're going to leave the whole network unplugged.
Welcome to Ground Truth, a conversation series about what AI must learn from the people closest to care. I'm Shreya Bhatt, Co-Executive Director at MEDIC. We steward the Community Health Toolkit, or CHT, and our global community of practice supports more than 180,000 frontline health workers across 24 countries with open source digital tools for last mile care. Today's conversation is really special because we're talking about what this AI moment means for professional community health workers and for the movement that's fighting for them. My first guest has spent nearly 2 decades delivering care door to door in Migori County, Kenya. Benard Otieno is a community health worker with the Lwala Community Alliance, and he delivers care using Kenya's electronic community health information system powered by the CHT. He's also spent years advocating for health workers just like him to be paid and professionalized. Benard, it's an honor to have you with us today.
Thank you, Shreya, for the opportunity. I'm very glad to be with you here in this interview.
We also have with us today Dr. James O'Donovan. James is a licensed medical doctor and the Director of Research at the Community Health Impact Coalition, a global movement making professional community health workers the norm worldwide. His work is all about turning what health workers like Benard do every day into evidence that shapes community health policy. James, so grateful to have you join us.
Thanks, Shreya. Great to be here and really nice to see both you and Benard. Looking forward to the conversation.
Benard, I'd love to start with you. Could you tell us a little bit about your journey? What inspired you to become a health worker?
Thank you very much, Shreya, for this opportunity to talk about my short and long life on community health services. It all began way back when I was just completing my high school, way back in 1996. And I immediately completed my studies. I felt like going to look for a job. So I went to the nearby hometown of Migori. And while I was there, I realized that there were some children. Most of them were under 5. And I realized that some of them were malnourished. But then the parents did not have the knowledge of how they could bring them up and bring them back to normal life. So I felt for them, and I thought inwardly that I will one day find a position to bring hope to such children, but I never knew exactly how and what position I would hold to do that. Then came the year 2009 when a local organization came to our village, look for people to be trained as CWs. I remember out of the 15 who were recruited to take the position, I was the only male among the female. So it was one of the unique things because at that particular time, CWs were more or less being related with midwifery. So they asked how a man could become a midwife. So it was not all that easy to start, but then all the rest after that is a story, and particularly positive story for that matter. Thank you.
That's incredible. So inspiring. Thank you for sharing that. I love that. I want to talk a little bit about the digital tools that you're using. You use Kenya's CHIC every day as you're planning your day, your visits, getting clinical guidance, seeing reminders, and so on. Can you tell us a little bit about how the tool has changed your experience of delivering care over the years?
Oh, sure. Every morning I wake up and as usual, I have my own family issues that I have to attend to. But then because of the community health services that I do, there are also things that I have to do daily to ensure that I offer my services to the community. So with the ECHIS that we use as electronic information system that we call ECHIS in Kenya, it creates tasks every morning. These tasks are brought about from what you had done previously. So when I wake up, I look at the system and it directs me on what I'm supposed to do during the day, the households that I am supposed to visit, and they are put in terms of priority. And normally you will find it brings about the tasks beginning the priority households where we have the young children under 5, places where we have the newborns, places where we have the sick, and also even the places where we have the pregnant mothers. So it will always direct me from which particular households I'm supposed to start my household visits and by which household I'm supposed to be ending my day. So that is how this makes the work easier. And I would say that actually the movements from day to day, you find it made easier compared to when we were just walking without anything that would direct us. So I would say that actually CHIC has made it easier for me to make planned movements and organized services in the community as compared to the old system.
I like that framing a lot. We often say at Medic, technology, it doesn't save lives on its own. I think it's more about what it can do and change when it's guiding and accompanying you on your visits and on your day-to-day routes, and how it really amplifies the impact that you have. So that's incredible.
Yeah.
And for the record, I just want to ask, are you currently using AI in your day-to-day at all?
I would say we've not started using much of the AI system in the day-to-day activities that we offer as community health workers in Kenya currently.
That makes a lot of sense. And I think that speaks to just how new and emerging a lot of the AI tools are in the last mile. Currently, a lot of them are still very much in pilot stage, and certainly very few have scaled. So I think that's really aligned. James, I want to pivot a little bit to you. The work that Benard is sharing and that other health workers do is incredibly skilled. And the coalition has spent years fighting for more investment in what we call the pro-CHW movement, or making sure that health workers are salaried, supervised, skilled, supplied. In this moment of AI, we know AI can cut both ways here. On the one hand, it could really make the case for more investment. It certainly helps ease the administrative burden for health workers. It can free up time for Benard, for example, to do the harder human work of caring and empathy and judgment and so on. But it could also be seen as maybe an excuse for kind of doing less investment, lower payments, fewer staff. You have a really unique bird's eye view across frontline programs, across governments and policy, and across normative bodies. What are you hearing about this, and which way do you see this moving?
I think something that I'd like to ground us in for the conversation is the survey that we ran across the coalition. And I think that is one of the beautiful things about the coalition. You do have that bird's eye view, and also you get to obtain and seek opinions from so many different people. So in the survey we ran, which was essentially asking community health stakeholders, how are you using AI at the moment, if at all? And then what are the challenges you're facing, and where do you see this going in the next 12 months? We had 283 responses. Interestingly, 76% of community health workers were using AI, and they were also the group that were perhaps most confident that the AI tools were safe and reliable, but they were also the group that were most worried about being de-skilled by them. So I think the first thing to say is that from the survey, AI has entered the community health space. And as Benard said, I think it may not necessarily be the AI people are thinking about in terms of generative AI or LLMs. It could be as simple as geospatial tracking, for example. But also, the interesting thing was that 51% of the community health workers were actually really concerned about de-skilling. And so I think the principle that Benard was discussing and you've alluded to is that the support and not replace is so critical. And I think that is the thrust that the coalition are pushing towards, that community health workers essentially are doing, as you pointed out, the really tough, hard things that can't be necessarily replaced by machines or robots or AI, which is the care that you give to people, going door to door, having these difficult conversations, and also knowing about that context in which you're working and the relational things that are so hard to replace. I think something else that we're seeing alongside that is that whilst AI has entered the community health space, we're also seeing that it's not necessarily being co-designed. So only 15% of the AI tools in use were co-designed with community health workers. I'll be honest, I was surprised it was that high. I actually thought it was going to be much, much lower. It's obviously still extremely low and too low. And that there were also concerns amongst all of the stakeholders, particularly the community health workers, that whilst they saw the promise that I spoke about a little bit earlier, They were worried about things like data breaches, privacy, being given wrong information. And ultimately, who does that responsibility fall to? Does it fall to Benard, who gets given an output to follow, but doesn't necessarily have the training or AI literacy to question whether or not that's right or wrong? So we're seeing some of these big questions coming up. I think there's some really interesting ways around where this is moving and where this is going. Everything's happening so quickly and almost too quickly that it sits both ways. It's great. There's investment and interest in this space. I think there's huge amounts of interest around things like clinical decision support tools, but not necessarily the really important stuff that Benard mentioned. As soon as he wakes up, he's checking ECHIS to make sure, who do I have to see today? Who's the priority? And I think that is the really important stuff in terms of helping with administrative burden, helping with deciding which patients you need to go see next. So it's not necessarily the most exciting stuff that might get funders from a technocentric viewpoint really pumped up, but it's the stuff that will make most difference to the community health workers who are actually going to deliver care.
I want to build on that a little bit more because you said something that's really interesting, this idea of the human in the loop. What is it that the human must do that a machine or a tool can't? But now I want to ask you, the notion here is that AI can do a lot of things, but ultimately the human must take that final call or take a decision or an action. When you're at the doorstep of a patient and the app is telling you one thing, but your own experience of providing care for nearly 2 decades is telling you something completely different, perhaps. Maybe this has actually happened to you. What is that process of how you navigate that? What goes on in your head and how do you go about making that decision?
You very much again, Shreya, for asking this question. This is a very important question. And actually, I would say that it is really true that AI would make our work as community health workers easier. But again, I would say it will never replace the community health workers and the services that they offer. Surely we would say that AI can also not replace the judgments being done by the human. You've just asked about an example of a situation where I would maybe have done a different judgment according to what AI directs me to do. And one good example that I want to give you is at one particular time, I went to a household, and this is a household that I had been visiting, but then the lady gave birth 2 months earlier than the expected time. And according to the system that I had in the ECHIS, it continued giving me the prompts that were giving me what I'm supposed to do when I'm offering services to a pregnant woman. But then in actual sense, in the household, the woman had already delivered. So it means that at that particular time, I had to do my own judgment and ensure I give the exact services that were supposed to be given to a woman that has delivered and also to the newborn that was now in the household. I had to give my own decision with my own experience and give the right services instead of following what the system was telling me to do, because according to the system, the lady had not given birth. So this is how, as human, we can only use AI to direct us and give us the right things to do, but we always have to supersede with our decisions when it comes to giving the best services that we need to give. Yeah.
Thank you, Benard. That's so insightful because I think it speaks to something that at an underlying level is really about trust, right? I think families and households in your community, they are not opening their doors up to an app. They're opening their doors up to you. And that trust is something you've built, over years, visit by visit, slowly. And I think when an app is right and it's guiding you in the right way, you're able to deepen that trust, or communities continue to trust in you. But if the app is wrong for any reason and you follow it for any reason, it's not the app's reputation that's at stake, right? It's your trust that could potentially get impinged. And so I think that's so key for us to remember as we think about AI and community health.
I think it also speaks to a bigger point, Shreya, here around that platform was basically giving Benard what it thought was correct and what he should do at that time. But it was relying on data that was technically not correct and it wasn't up to date. And so the information that we're getting from AI-powered tools is only as good as the information that's going into them. And so it relied on Benard knowing, okay, this is not the right time given the context of what has happened here. And also Benard feeling empowered and having that knowledge to know what to do correctly. And I think over time, that is something that I have some concerns around, especially in terms of the authority to have to override a all-powerful tool. And secondly, the potential de-skilling of health workers. Bernard clearly knew this was not the right thing to follow or the right protocol to follow. So he could rely on his 20 plus years of experience to say, I'm going to go and do my own thing here that I know is correct. And so I think it flags a really nice point there as well around autonomy and the ability of community health workers to make the decisions they know are right for the patient in that household.
Absolutely. I couldn't agree more. James, I want to go back to something we were talking about a little bit earlier around AI in community health, and that's from the angle of pilotitis. Slightly uncomfortable in the digital health space, but this idea that many pilots get launched with a lot of fanfare, and certainly it's something we lived through with mHealth 1.0, if you will. Maybe there's a paper or two that's published and then they fade away into this valley of death almost. And it seems like we're living that same moment perhaps now with this huge surge in AI pilots and experiments washing over community health. I'm curious what your honest take is. Is this sort of just the newest version of that same pattern that we've seen earlier, or is this something truly different now?
I think the simple and easy answer is it's the same, given that it's backed by the data. So we also ran a poll of 28 NGOs that we work with at the end of 2025. Things are moving very quickly, so do take this information and data with a pinch of salt, but I think it does portray the general theme quite well. Of those 28 NGOs running programs across 18 countries, 61% were piloting an AI tool. So obviously widespread uptake, widespread interest, but only one organization, so just 4% of the sample size, reporting that tool was meaningfully integrated into local or national systems. We've published that information in Lancet Primary Care with a group of 48 collaborators. And I think in that way, the risks of pilotitis, as you described, are at risk of just repeating themselves again. In some ways, it does feel different to Digital Health 1.0 or the health era for two reasons. One is the speed at which things are happening. Things just feel like they've sped up 10, 100x. And the other is the money that's flowing into the space. So there's obviously just widespread interest at the moment and almost a fervor where groups, be it frontier labs or big funders in the international development space, are pouring hundreds of millions of dollars into this area. So I think the big challenge here is the checks are bigger, the cycles are shorter. That means we could actually end up making super costly mistakes at a much bigger scale. In some ways, though, it does feel different. Number one would be that we should hopefully know the past mistakes that were made in era 1.0. And the question is, are we willing to learn from them? The second is that I think there has been a shift in the sector to get more input from community health workers. So this idea of nothing about us without us that CHIC have really spawned and really taken forward has become more of a norm. So you now see community health workers like Benard being at UNGA, at SCOL, speaking on panels, having their voices heard. And I think making sure that Benard's perspective and his colleagues are front and center of any design or evaluation process is so critical. And I think that norm is being more entrenched in the space. I think the third area where hopefully there has been an improvement over the last 10 years is a willingness to collaborate. And so in a space that could typically maybe be seen as driven by some competition or an unwillingness to collaborate, I do think the coalition has really tried to change that. A good example would be the data harmonization work we did several years ago, where a number of member organizations of CHIC pooled data that had been collected, looking at things such as speed, quality, coverage of care, and trying to track what were the things that made a difference to, for example, women delivering at health centers. And that information could then be shared across the coalition members so people could learn from each other. And then I think the other big thing that hopefully is slightly different. Is funders willing to have this open dialogue? And so we've just finished a consultation process with a couple of funders trying to help them understand the landscape in terms of mapping how AI is currently being used, but then also getting direct inputs from NGOs, community health workers, community health stakeholders to try and inform those future investments. So I do think the statistics suggest mHealth era is repeating itself and pilotitis is repeating itself. But hopefully there are some positive chinks of light where we might be able to make a real change and difference.
To pick on a thread that you mentioned, there is certainly this hype around AI as this shiny new thing, and certainly a lot of money flowing in to support AI pilots and opportunities and explorations. You mentioned a little bit about the costs involved here, and I want to tease that out a little bit more. When you have this surge in pilots, certainly some fail, a few, maybe more than that, might reveal some important learnings, and some may eventually scale up. I'm curious what we think about who ends up paying the highest cost for things that fail, things that don't succeed, or things that perhaps even do damage to the gains we've collectively made over the years. Is that the health workers? Is that patients, implementers, the funders? And how do we think about those costs?
I think if we look at it from an economic lens, when we talk about costs, it's important to define what you mean by costs. So of course, there are the financial costs or capital costs. So for example, a lot of money pouring into the space, not necessarily being used in the best way. And to be clear, I do think pilots have a space. I think they often get a bad reputation, but that's just because it's pilots that are designed poorly and not necessarily with the end goal in mind. So whenever you start a pilot project, ultimately you should be thinking about its route to scale. So what happens if that pilot is successful is that hopefully it would happen at scale and then get embedded into national policies, etc. There also has to be a willingness to say when a pilot is failing that you have to have the humility to say, this isn't working and that's fine. We can pull the plug on this, but in a responsible way. I think who bears the ultimate cost here is not just all of the money that's being poured in. So that would be the funder, but ultimately the costs in terms of trust. So for example, this is where Benard would be able to speak about this much more eloquently than I could. But if you have a community health worker who is constantly rolling out or being part of pilot studies, testing various fragmented vertical apps or solutions or AI tools, ultimately that is a drain on their time and energy. It's also harmful for the community if there's a lot of fragmented studies that are going on where you're not seeing any real feedback loops and people aren't really learning from those areas. And ultimately, the community health worker is the one who's going to absorb all of this responsibility and also be the person left there to try and explain to community members, this is what happened to project A, B, C, D, all the way to Z. And I've seen that myself. I've been working with community health workers for over a decade. I've spent a long time with community health workers in Uganda and I lived with many of them. And I'll never forget when I used to actually live with one of the community health workers. She would have 10 separate mobile phones, all charging, all with different apps on them, for different projects, some of which had come, spent 2 or 3 months with the community, left, never to be seen again. Others would be ongoing, but that was the burden that she had to carry. And ultimately, we have to remember it's the people that she's serving, so the community members and patients who we hope no harm will come to through this. But if it's a poorly thought out pilot that isn't meaningfully integrated into the system to make a meaningful change to individuals' health or community health outcomes and metrics, then I think that's another important point to think about.
I just wanted to jump in 2 comments about what James have just talked about. The first one is who foots the bills for the digital tools or maybe these particular pilots that have not been picked and they have not been integrated into the system. I want to say 2 people here will always foot the bill. The first person is the taxpayers. Whoever gives out these amounts of money to be used for all these pilots will always see it as a loss on their end because it has not given them the rightful thing that they wanted to be the end results. And therefore, it's like a money lost somewhere in the thin air that has not been properly used. And then the next person who also feels this bill is, as James has just cited, the community health workers. I remember at one particular time, we were given like around 4 apps. And just the rightful way James has put it, we had 3 different phones, and every phone had a different app. But then, confusingly enough, 2 of them were doing the same thing. Each organization was doing a pilot on an activity which was similar to their other one, which means that if this had been integrated into the system well, then the data would just be picked from one particular point to be used somewhere. But then when we went to a household, I remember very well our household head asking me, is this not the same thing that you had done just 1 month ago? And I had to explain myself and make the household head understand that even though it looked the same, but it was coming from 2 different organizations. And this sometimes make these people, some of them even ask for money from us so that they offer the information that we need from them, because they tell you, you just took the information the other day. Today you are back again asking for the same thing. So you have to give me something in terms of finance so that I give you the information. So actually the community health workers will foot the bill in terms of trust by the community. The second part that I would move to is that there needs to be a collaboration between partners who would like to do the same thing, so that when they come up with something, then it is one tool that is going to monitor all the things that every organization would like to get from the community.
I think that's going to stay with me, this framing of certainly collaboration, but also being really thoughtful and mindful about co-design, like you said earlier, James, and thinking about the path to scale early on, even if you are still at pilot or pre-pilot. I think those are some critical learnings that I think the community has learned through mHealth 1.0 and certainly applies more than ever, I think, in this moment of AI. Maybe, Benard, back to you, a question on, as we talk about all of these AI tools right now, the decisions that are being made for these tools, how it's being shaped, how it's being designed and thought about, are getting made far away from you and far away from your day-to-day reality, perhaps. If there's something that you might say to people who are building these tools, who are implementing them, who are funding them, what's that one thing that we should keep front and center, like James was saying earlier?
One thing that I would tell decision makers when I sit with them, and that need to be taken into consideration in every design that is being made. Just as you say that most of these designs are made away from those who use them on the ground. Making these designs away from the community health workers that are going to implement them at times make or leave some loops in between. Some gaps are left because somebody somewhere is designing something that he himself, he has never done. But then with the inclusion of the community health workers during the design period, then it will make it easier such that when it is now being implemented, then it had already taken up what is going to be done on the ground. And therefore, one major thing I would like to say is that in every stage of development, a community health worker that is going to be implementing these particular things must be involved on the table to give the first-hand information from the household level. And I want to thank some organizations. Just last year, I had an opportunity to attend Global Health, Digital Health in Nairobi, and we had a good time talking about AI. That was a great experience. We were around 5 community health workers in the room, and the experience that we brought on the table actually changed everything that those who were there with us thought they had made better, but they found that what we were carrying with us was the best to be taken up. So in every table where these designs are being discussed, a community health worker need to be there. That is in the spirit of nothing for us without us.
I think that's certainly the ethos that CHIC has brought to so much of the coalition's work and that many organizations like ours have been supporting as well. So I love that you shared that. Thank you, Benard. James, maybe zooming out a little bit, I'd love to talk about what it means to be advocating for CHWs in a moment like this. And I'm thinking the kind of advocacy that CHIC does, it takes time. It's sometimes a journey of years. And to your point earlier, AI right now is moving at the speed of months. And I feel like there's an inherent tension there. On the one hand, if we are setting some norms too early, we tend to lock ourselves into what we know to be true right now, which may not necessarily hold in a couple of months or certainly within a year. But I think there's a risk of, if you wait too late, are we going to see this proliferation of hundreds of incompatible pilots ending up in that valley of death, the waste of resources, the waste of opportunities to really make impact? How do you think about the right timing to set norms? Is there a balance to be struck here between being prescriptive and also being agile? How are you thinking about that?
Again, it's backed up with the survey data that we published. So we found that 14% of stakeholders said that AI policies were clear or that they even existed. In terms of norms, the question for us isn't necessarily early versus late. It's basically choosing what to bind and what to leave loose. And so we've suggested it's important to bind the things that don't age. So those are like the slow moving fundamentals. So things like human oversight of clinical judgment, human in the loop, data protection, community health workers' role and status. Those for us aren't necessarily the sort of technology questions, but they're more the value questions. And they're going to hold true in 10 years as they do now. I think the things to leave loose are the points around the specific technologies that are being used, because that's going to change in the next couple of months. Thinking about specific use cases, models, etc., are the areas that don't necessarily need firming up. I think it's never too early to set norms. And again, going back to that sort of values question, we need to ask what is important in this space. And the right people to set those norms are the people like Benard. And I think all too often, community health workers and importantly, community members have been left out of that norm setting process. And that's something that we're hoping to change at the coalition through this radical collaboration.
I think that makes a lot of sense, especially when it's the technology that's evolving quickly, but so much of the philosophies and the ethos behind these do need to stay stable, and we need to have collective clarity on them. To build on that a little bit, how do we think about enforcing a norm, especially when we aren't in the enforcement business, but we're in the advocacy business? What does it look like? I know with the pro-CHW movement, CHIC has used things like published research and standards building and encouraging some public commitments. What do you think is needed now to make norms stick, especially in this moment around AI?
It's a great question. So I think no one organization can enforce a norm. And I think that's where the coalition comes into its own. When you have a group of organizations, a group of members and allies working collaboratively together to try and shift the way a field sees something, that does take time. And I think that's going to be the sort of biggest tension between AI, where things are just moving so quickly, and then entrenching a norm that just takes time, because you need to build trust. You need to often repeat a message 10 times before people start to realize, okay, this is this group who are talking about it, never mind, act upon it. I think something that I found especially valuable at CHIC is to think about this three-pronged approach we take. So you have the research work that I work on with hundreds of members, and that's to think about gathering the best evidence. And so is that evidence going to be quick, rapid, responsive? And is it going to be something that policymakers and funders are going to pay attention to? And so I think making sure you have accurate but also responsive evidence is really important, because ultimately members of ministries, be it ministers of finance, ministers of health, need something solid to anchor their decisions to. If they're going to spend $100 on an AI solution for community health, you've got to trade that off against, should you spend the $100 on bed nets? Should you spend it on mechanisms that are already proven to save lives? So the first element is good evidence that's quick. The second is making sure that you've got the demand both from the top down and bottom up. And so at CHIC, we have that through huge numbers of community health workers forming associations to drive that demand from the ground up. But also you need it from top down, meaning you need to have the ability to influence the norm setters at a national as well as international level. And so the three-pronged approach of research, advocacy, and activation is something that I think is really important. And also just remembering that no one all can do it alone. So like I mentioned, you're going to need a collective effort of everyone who is a stakeholder in this space joining together, not necessarily agreeing in an echo chamber. I don't think that is healthy, but having positive, constructive debate and feedback to ultimately decide on the best route forward. And I think something that's so important throughout the whole process is thinking, who are we doing this for? So it's not for the funders, it's not for the boards that we report to, it's ultimately for the communities who we're trying to serve. And so having community members, be it Benard who represents community members or actual community members who are being served by these solutions or tools as part of that process is critical.
I just want to press what James is talking about. Norm setting is a process. And just the way James puts it needs collaboration top down and then bottom up. Actually, let me just deviate a bit from AI and say that when we have to change the norms, then there are certain things that have to change from the bottom. Let me just use an example of payment of community health workers. This has been a problem globally, but you find that there are certain countries where they've now started paying the community health workers, even though they may not be at the standard charges, but actually some of them have tried to pay the community health workers. This to happen, it means that a country or the management of that particular country will have to form some policies. So these policies actually will make the norms that had already been placed to be replaced by better norms that can bring better things. That applies to even AI. It means that for AI to have its space, then it will have to set the norms from the people who are on the ground and also by the policymakers that will make these norms stick in those countries to implement them.
And I would agree with Benard. I think a critical thing for a norm to be set is to identify things like policy windows. So where do you have the ability to enact something that is timely and also is likely to get the ear of the people who are setting some of those norms? And also, I think the other critical thing just to tease out is that you could have an AI policy, although we know that 86% of the countries surveyed don't necessarily have them, or at least they're not clear. But that policy is only good if it then gets acted upon. And that's where it's critical to engage with the frontier labs, the people producing the technologies, the district health officers who are deciding how those are being funded and used, with the community health workers who are ultimately delivering them. So I think it's going to take this multi-pronged, multi-stakeholder approach to not only set the norms, but then also make sure those are enacted upon.
I think that's really an argument for, or kind of a testament to the power of coalitions, right? Because to your point, James, I think no single organization, as you said, can do this alone. And certainly no single funder is going to be able to achieve all of the impact. It takes all of us together to work on this. And I think even if that means we're slower a little bit than moving alone, I think we go further and we make a deeper change. I see so many parallels with Medic's role as a steward of the community behind the CHT. We've known no single organization can build digital tools that scale and that are locally owned. Now that are AI powered, for example, and no single funder can carry it, it really takes collective action to keep it alive and keep it relevant for evolving needs of communities around the world and keep it the critical public infrastructure that it is. So I really like that. All right, as we come to the end here, I want us to look forward a little bit. James, in the next 6 to 12 months, is there that one norm you think, or that one sort of line in the sand that we really need to be drawing collectively on AI and community health? What's that thing that we can't afford to ignore or stay silent on?
It's a really great, huge question. I would go back to the very beginning and echo Benard's point of the principle build with and not for. Given the fact we're heading for this shortfall globally of 43 million health workers, community health workers are the largest primary health network on Earth. And it's also one of the space's best early warning systems, be it for outbreaks such as Ebola or as we saw during the COVID pandemic. I think if we get AI right, it can be a genuine co-pilot for that workforce. But if we get it wrong and we deploy it without the people, the training, the professional foundation underneath, we're going to leave the whole network unplugged. And so I think the critical thing is making sure that community health workers are involved at every stage of the process, from initial ideation through to design, deployment, evaluation, and then importantly, feedback. So we close that whole cycle. And I think without people like Benard, who are going out door to door every day in the community, we can't do things that are meaningful. And if we want to go fast, we would go alone on these things together. But as the proverb says, if you want to go far, then you're going to have to go together. And so I think it's going to take this collective effort of making sure we're always thinking about who we're doing this for, but also making sure that we're going through this process together. And although it might feel like we need to move quickly and be reactive, it's important to always take that step back and make sure we ask ourselves the question, are we doing the right thing? Are we doing it safely and ethically? And are we doing it for ultimately the people this tool is designed for?
And I would add to that as well, James. I love the sort of, are we doing it responsibly? I think a lot of the design and sort of resilience learnings from earlier experiments also hold true here, right? Are we doing it with the thought of scale and local ownership in mind, and doing it in ways that augment and not impede a health worker's experience day to day, and ultimately actually augment the care that the communities receive? That's terrific. Thank you, James.
No, thanks, Shreya. And I think I agree with you. That should be, as we spoke about earlier, the norm. Those are the norms that we need to make sure are entrenched and just seen as the way we do things, not necessarily focusing on the technocentric viewpoint of which specific model should we be using and maybe for which particular use cases, but exactly what you mentioned.
Terrific. Benard, I want to give you the final word and question here. When you think about AI coming into your work, what's your biggest hope? What do you want it to do for you and for other health workers like you, and importantly, for the many, many households and families that you serve every day?
My biggest hope when AI comes into the space where I work is to make my work more easier, to make my work more accurate, and to make my work more efficient. By doing that, it means that the end receiver, that is the household, the community that we serve, will always get the best. And what we do as community health workers is always to make sure that whatever service that we offer is given to the best status to the community that we serve. Therefore, when AI comes into the space, then my hope is that it will make whatever services that we do, the community become better than it used to be and give the best services that we can offer.
Amazing. What a lovely way to end this chat. I think that's going to stay with me, Benard and James. Benard, thank you. You took us to the doorstep today and gave us a peek into what it's like to build and earn trust that you have over the years. And that's exactly the ground truth that this show is named for. So such an honor to speak with you. And James, you've brought us your unique lens of what it takes to translate Benard's lived experience into evidence, into policy, into norms that can actually strengthen health systems and really improve health for all. So the work that you and CHIC are doing are invaluable, and such a pleasure to speak with you today as well.
Thank you, Shreya. It was great to be here. And also, Benard, thank you for all of your insights as well. It's always amazing to work with you.
Thanks for the chance. We hope that whatever we say will always help in improving the living standards of the community at the ground.
Amazing. To everyone listening and watching, if this conversation was insightful, please do subscribe to our YouTube channel so that you don't miss what's coming up next. And if you know someone who's interested in AI for good, who's working on AI for community health, thinking about some of these same themes, do send them this episode. Thank you so much, both of you, and see you next time.